Welcome to the 54th Interscience Conference on Antimicrobial Agents and Chemotherapy, or ICAAC, and this is ASM Live. I'm Michael Schmidt from This Week in Microbiology, and we're very fortunate to have a special session of ASM Live where we're going to learn from the researchers investigating this current Ebola outbreak in Africa, who are going to share with us some of the exciting results that they have learned researching this virus, and more importantly, how they've been taking care of patients. Joining us this afternoon are Dr. Barbara Knust from the Centers for Disease Control and Prevention from Atlanta, Georgia, Dr. Aneesh Mehta, also from Atlanta, Georgia, but the Emory University Hospital System, and Dr. Gary Kobinger from the Microbiology Laboratories of Canada that are located in Winnipeg. So thank you all for taking time from this very busy schedule here at ICAAC to sit with us and field questions from the press as well as the general audience. The press will ask questions, and the general audience can send in questions via Twitter or our online chat room. So I'm going to start with you, Dr. Knust, and if you could just provide us an overview of your role in combating this outbreak.
Okay, thank you very much. We first got started, and really CDC's involvement in the Ebola outbreak started in the end of March when we first found out about the laboratory confirmed cases that were in Guinea. We sent an initial team to Guinea as well as a team to Liberia to help respond to the outbreak at that time. And over the course of the next 2 months, we had approximately 20 CDC staff that went out to the outbreak and helped out with things like data management and helping us set up contact tracing, basic epidemiological skills that are needed in the field to get the outbreak under control. In the end of May, we had people coming back to Atlanta again because it was appearing that the outbreak was slowing down and quieting down. And just as soon as we came back, that's when there was a resurgence of cases, really fueled by the resistant communities that were in the area between the borders of Guinea, Liberia, and Sierra Leone. We sent people back out to the field again in June, and we activated the Emergency Operations Center for CDC in July. And since then, we have had a lot of activity and have grown bigger and bigger in our response. Currently, we've had approximately 90 people sent to the field since July, and they've gone to Sierra Leone, Guinea, and Liberia, but also to Senegal, to Nigeria, and we have plans to go to additional countries just to help with preparations for countries that may have people that would be coming there that might be infected so that they're ready. We also have a lot of, and the kind of work that we're doing in the field includes the basic epidemiology that I mentioned before, also helping the countries, the ministries of health with setting up incident management and working on things like exit screening so that people who are symptomatic with Ebola are not leaving the country. Working on infection control, that's a major push that we have, as well as laboratory support. So we have a lot of different fronts that we are putting forth and working with our international colleagues to help with this outbreak. It's been a major effort. There's been over 500 CDC staff that are not in the field but are just supporting it from Atlanta and from our various locations.
And you're going to be giving a much longer talk here at the meeting this afternoon at 4:15. Dr. Kobinger, your talks already went off, so you had a standing room only audience, I heard, and unfortunately I was here, so I wasn't able to hear what you taught us at ICAAC. So can you share with us what you reported in the last hour?
Yeah, so briefly I shared an overview of the outbreak from the beginning and when it started in Guinea and the illustration, how it evolved and how it is now in Sierra Leone, and including Sierra Leone and Liberia. I showed on the side a little bit of what we are doing more specifically, which is a small contribution to the outbreak. Public Health Agency of Canada has deployed a mobile lab. Initially, we arrived in Guinea, but as we arrived there, we were asked to go help with diagnostic in Sierra Leone, which we did, and we still we have a presence in Sierra Leone. So one of the lab in Kailawan is being managed by the Public Health Agency of Canada with the help of MSF. So mainly this was the main focus of the talk. I touched also on therapeutics that have been hot topic recently. Also in the context of the very recent WHO meeting that just was ongoing and just finished on Friday in Geneva, and that was it.
So, Dr. Mehta, you're on the front line. You were actually one of the attending physicians that took care of one of the first few cases of Ebola that actually came into the United States, the very famous ones that came on jets that actually then were transported to the CDC. We all followed the ambulance traffic and the motorcycles, and you actually put your life on the line as you began to take care of those folks. So why don't you tell us a little bit about what you learned?
Well, thanks for having me. And I'd want to make one point of clarification. I think the real front line is in West Africa, where Dr. Kobinger has been. I am a member of Emory's Serious Communicable Diseases Unit team, and we were fortunate to be able to take care of 2 humanitarians who unfortunately became infected while trying to take care of patients in Africa. I hope that the experience of our team, which includes physicians, nurses, laboratory technicians, chaplains, nutritionists, etc., I hope that experience, that we can communicate that now to the broader medical communities, both here in North America as well as in Africa and other parts of the world, so that we can learn from our experience, even though it's 2 patients, some clinical pearls that might help others. And the other thing that I think our team was very fortunate to learn is to have great collaborators and support from the CDC, from the FDA, and the Public Health Agency of Canada, amongst many others, to really help direct the care and provide information into how to care for Ebola patients.
So we'll take questions from the audience.
So we have 2 questions online. Both are for Dr. Kobinger. The first is a question from Melanie Gantz at the CDC. Do you have any information about the suspected Ebola case in Montreal? If there is a positive case in Montreal, what procedures will be put into place?
No, I don't have information right now. I mean, there was a few suspected cases in Canada, like there was in a lot of other countries. And I can guarantee you one thing, though, is if there will be a confirmed case in Canada, there is procedure in place and the response will be immediate.
Very good. Second question for you as well. It's from Rob Nickel of Reuters. Dr. Kobinger, when do you expect the Canadian vaccine to move from the Winnipeg lab to Africa?
I don't have a date. I could only speculate on it. You know, the discussion that happened just at the end of last week in Geneva, I think were very helpful in that context to, you know, to have the right framework in Europe and in West Africa in order to receive it's not only to receive the vaccine, of course, the vaccine needs to be shipped so that it can be used. There is phase 1 clinical trials that are being scheduled right now. And, you know, I think, again, that I don't have a precise date, but as those discussions evolve rapidly in the current days, I think we'll probably see something coming very soon in terms of at least some tentative timeline. But, you know, the challenge is there's a lot of discussion that needs to happen where it brings a lot of people together from the regulatory side, from the clinical side, from coordinating all this between, you know, it's easy to say, let's do a clinical trial, but it's very complex, specifically in the current situation where, you know, the focus is really on the outbreak response. And so you want to move things forward without having a negative impact on what's already a difficult situation.
Yes, I'm Dr. Thompson in Tuba. My question goes to Dr. Knust, and I suppose that I'm referring my question to you because you are almost the top person who should be representing the government of the United States as it relates to this public health emergency. Basically, you gave us information that the CDC was aware of this problem since March, and that the CDC had mobilized resources to Africa, to the places where this problem had started, and that it developed over a couple of months. You are pretty aware of the fact that the international community has actually been condemning the international response to this problem, and there are those who believe that if those who really have the resources, like America, Europe, and some of the other rich countries, had actually done enough, fast enough, the mortality that we have will not be there. What would you say in terms of what you present as a response from your agency, which maybe by your estimation it was adequate, and the complaints from the international community?
And so it's always difficult to mobilize resources in a timely fashion, and the international community now is really moving very quickly to mobilize resources. At the time and in the area where the outbreak has really taken off and spread, it appears that there was a perfect storm in terms of having a very easily mobile community, and a community that was resistant to the outbreak control measures that have been used. And the efforts that were made at the time really for previous outbreaks should have been adequate, but I believe that the circumstances were such that it was able to move beyond what the resources that were put into play initially were there, and so that's why we have the situation that we're presented with now.
So while Jim's moving to the next one, do you think it's an issue of logistics, or do you think it's an issue that the virus may be a little different?
I think it may be a combination of several different factors. We certainly are interested in the question about whether there's any difference in the virus in terms of its behavior. However, from the basic standpoints of the kind of public health measures that we have used in over 20 Ebola and Marburg outbreaks in the past, those measures still need to be put fully into effect. And so we know the measures in terms of having adequate infection control, good burial practices, those are time-tested things, and we know that they're not currently adequate for the number of Ebola patients that are out there. And so that really is very essential to put those into play and to think about additional measures that we can take that can really be enacted rapidly.
Hi, Simeon Bennett from Bloomberg News. Question for Dr. Mehta. The two patients who were treated at Emory, is it correct that either one or both of them was treated with both ZMapp and with convalescent plasma? And if so, how do you tease apart the effect of both of those? Is there a way of knowing whether one was more effective than the other? Which of course is relevant in the context of the WHO meeting that Dr. Kobinger was just at, recommending that convalescent plasma be used as a priority therapy in West Africa. And then secondly, you said that there are some pearls of wisdom that maybe come out of this experience that could be transferred. And is that really, I'd be interested to know what they are, given that the situation here in the US and the level of treatment that these patients got is a world away from what patients in West Africa are receiving. So is there really anything that can be genuinely transferred from your experience here to West Africa? Thank you.
So I'll answer a little bit of both questions first. It is really hard to derive a lot of meaningful data from the care of just two patients. So while we will report what we did and what we believe happened, I don't think you can generally take that as to inform more basic care of everybody with Ebola. So going to your first question, one of our patients did receive a convalescent blood transfusion while over in Africa, and I think he's already reported that to the media. We, again, just in one patient in one time course, will not be able to tease out the effect of that product versus the ZMapp versus the supportive care that we did. It is too little data to make those sort of conclusions.
Hi, Nell Greenfield-Boyce with National Public Radio for Dr. Kobinger. How likely is it that this virus could mutate in a way that would make it start spreading more easily?
You know, that would be very speculating on what can happen or cannot happen. But I can tell you this has not happened in the past in any of the outbreak where a virus evolved, an Ebola virus or even Marburg evolved in a way that it was spreading more efficiently. This is a unique situation in terms of the spread and the number of cases and the amount of space involved, of course, like within all those countries. So we'll have to see, but it would be just speculating on what can happen or not with this virus. We're in a unique situation, but again, if you look at the past, this has never happened, where the virus has evolved into become more transmissible.
Have the respective national laboratories in Canada, the U.S., and Europe, have they sequenced every isolate to get at the question whether the virus is indeed evolving as it goes through this epidemic?
But there was a study that just published recently that has done a lot of sequencing of a lot of different isolates. We haven't sequenced every isolate. I mean, really our focus is on trying to control and to provide diagnostic on our side. And we also help to standardize all the assays from different labs because there are so many labs right now in the field. So we haven't taken the time to sequence. But again, I would suggest to read that recent study. I would think that has looked at. But one thing that I can mention is, from one outbreak to the other one, there's not a lot of variation within the Zaire group, and that may suggest that there is such a pressure to have always the same phenotype and genotype of the virus to emerge in the human population.
Another question.
So we have several questions coming in from Canada. Melanie Gantz has a follow-up to her original question about the procedures. She'd like you to be more specific about the types of procedures that would be in place in case there is an Ebola case in Montreal.
I mean, I don't mind going more specific. It's just we could also have, I guess, this talk offline in terms of, or indirectly, so it does not take the time for everybody. But for example, if there would be, so the way it works in Canada is the sample are sent to Winnipeg, as in the US, they're sent to CDC. And if there will be a positive case, of course, communication will be immediate. We have expertise that we could share with provinces that will request it in terms of infection control, in terms of more lab diagnostic needs, in terms of clinical care, in terms of, not the clinical care is a provincial responsibility, but the managing of the sample from a technical perspective. How do you get those samples tested for clinician on the site to be making informed decision? NML could provide help if there would be a request. So these are examples.
Dr. Knust, what would happen in this country, in the United States?
We actually have had a few different inquiries that have come in from state health departments and from hospitals. And we help with, in terms of clinical consultation, there is diagnostic testing that CDC can carry out, and there is also diagnostic testing that can be carried out in some select state laboratories. And so once there was a patient who looked potentially suspicious, there would be activities at the local level to start identifying people that may have had contact with that person without the appropriate personal protective equipment. And they would start to identify people that might be needed to be followed in terms of if they develop any symptoms. If the laboratory confirmation did occur, then those people would be followed to be in the general concept of contact tracing, that if somebody who is a contact of an Ebola patient develops symptoms, then once they develop symptoms, they would also then go into care where people were using the appropriate personal protective equipment to care for them so that there was no more human-to-human transmission. So contact tracing would be a very important component. There would also be a team of people that would be providing the appropriate infection control guidance for the people caring for the patient at the hospital. The discussion about potential therapeutics certainly would be ongoing, and making sure that the patient got the appropriate care. And then also a lot of work in terms of communications for the public and communications for healthcare workers in general. A lot of work to just ensure that the patient and people that may have had contact with them were quickly cared for and followed so that there would be no more human-to-human transmission.
Again, Erica.
All right, so another question from the chat room, also from CBC. It's Karen Paul. She has a series of questions for you, Dr. Kobinger. The first is, can you tell us where the most recent mobile lab has gone, and is it replacing the 3 Canadian scientists who recently returned home?
Yes, so as it was discussed before, so that one of the team was brought back to Canada, so another team now is back to Sierra Leone, and will be taking over and offering doing the same job that they have been doing before, so rapid diagnostic.
And she follows with a couple more questions. And are you planning to go over with them?
Right now, there is another outbreak in DRC, and we have had a very long relationship with DRC, and we're supporting them fully in this too. So I'm actually looking at going to help in DRC.
And final question from Karen Pauls. What health safety conditions have changed to make it safe for them to return?
The environment has changed. That's the difference. As it was disclosed also and discussed, the problem when we brought them back is that there was cases that were found in the environment where they reside, so at the hotel. And it was very hard to do a risk assessment from Canada, of course, and we didn't know exactly, there was no, they were very low risk. There was no indication that they had been really exposed, but there was question marks that we couldn't answer efficiently. So it was just much better to be safe and to bring them back and then to send another team. Now the hotel has been completely cleaned and is being actually managed by MSF. We're working very closely with them, and they are the most experienced in managing these sites. So we feel very confident that the risk level is very low right now.
Thank you. I'll address this to anyone on the panel who wants to take it. Joe Haas from Informa Business Information. There have been headlines, and I don't know if this pertains to the Canadian vaccine that was referenced earlier, but headlines about a vaccine in animal testing, particularly in monkeys, that has shown efficacy but needs boosting. Can anyone brief us on that? Is that potentially a possible answer in this current outbreak?
Which one of you?
I can start. So are you referring to, so there's 2 vaccines right now that are moving forward for clinical trials. One has actually started here in the US, is the vaccine based on chimpanzee adenovirus. There's a second one based on VSV, called VSV, that will start we're expecting in the next few weeks actually. And is it going to have an impact on the current outbreak? It's everybody's guess, but I would think it's possible because, if phase 1 data are being made available in the next few months, I don't see the outbreak, but I really hope, trust me, I really, and we're working hard towards that goal, but it may be that when phase 1 data are made available, the outbreak will still be ongoing, and if this is the case, there will be an opportunity for those vaccines to be playing a part, at least in the healthcare workers and maybe, again, control setting. It will have to be decided with regulators and others, but it's very, very encouraging to see that in response to all this, there was a lot of people that got together and made those things happen. These phase 1 clinical trials were not scheduled to happen so quickly. And this is a lot of work, so I know a lot of regulators have spent countless hours on making this happen together with, companies that are making the vaccine, for example.
Hi, Nathan Seppa at Science News. For Dr. Kobinger and the others, looking ahead as somewhat untested vaccines and drugs get put into the field, how easy will it be to have a protocol that actually produces evidence that they are changing the status of the patients, and what are the risks?
Yeah. Well, again, there's always risk and there's always benefits, so it's a risk-benefit ratio, and it needs to be evaluated. As I showed during my talk, there's a group of people that when they start initially with very high viral load, they have very low chance of survival. So these, for example, are groups that could be more easily targeted in terms of being offered an opportunity to an option like a vaccine. And the phase 1 clinical trials this is why they're so important, is because they offer the right environment to have, these are blinded or double-blinded, placebo-controlled, so there's a control group. You can really understand what the benefit is, if there is to be a benefit, but you certainly can understand if there's a risk and what safety concern one may have. And to move to a vaccine like this also is very important, because maybe one will do better than the other one, and maybe both will be as good, and then it offers more options. So that's I think is very important. I don't want somebody else to say.
So I think one of the important things that as a clinician we want to learn from these studies, we might not have the best studies done, but if all these agents move forward and become studied, and it's great to see this mobilization for those research efforts, we might be able to better understand which drugs work or which therapeutics work best for particular situations in Ebola. And as Dr. Kobinger mentioned, patients with high viral loads may benefit from one type of agent, and patients with other presentations may benefit from a different agent, and we can selectively use our therapeutics to be specific for that patient.
Hi, I'm Julia Balluz from Vox.com. Thanks for your excellent answers today. I had another question for Dr. Mehta, following up from the first question from my colleague at Bloomberg. You didn't answer about who actually, like how many doses of the serum were given to each patient of ZMapp. You mentioned the convalescent serum, but not the specifics about ZMapp. And then another question for the panel about how this particular epidemic is changing our understanding of Ebola. If you could just comment on that. Thank you.
Sure. So as has been mentioned in Dr. Kobinger's talk earlier today, as well as in other releases, that both of our patients completed the 3-dose course of the monoclonal antibody cocktail. And then also to follow up on Mr. Bennett's question from earlier, one of the ways that we think that we have been trying to use our experience is one of our patients was a physician there in Africa taking care of patients with Ebola. And so we were continuously speaking with him about the results of his own care, and also speaking with his physicians in Liberia, and hopefully letting them know how things changed and how they might implement some of the things that we found were helpful to their patients, and we got a lot of positive feedback. We've also had a very nice opportunity to talk to other physicians in Liberia, in Nigeria, in Europe, and in North America, who are either taking care of patients with Ebola or are preparing to do so. And it's been a wonderful experience being part of this larger medical community, all of us trying to prepare to take care of patients.
Speaking to your question about how this changes our perspectives on Ebola outbreaks, I think this outbreak or epidemic, if you would like, has changed or has really driven home the importance of having security in global health, and how a weak public health infrastructure in one corner of the world can really have a ripple effect across the world. I think that really has driven home in a very major way how the African healthcare setting and in the outbreak-affected countries, I believe that it's probably very representative for the healthcare setting in much of Africa has a long way to go to prevent a lot of diseases. The Ebola outbreak really has just driven home how the inadequacy that's there and the really just the effects of that and how the effect of one disease outbreak can cause a whole country to go into a crisis, in particular in Liberia. That really is just emphasizes the importance that we all need to take and work on strengthening the healthcare systems and the public health systems, not only in our own countries, but in particular in countries that have a long way to go.
Hi, I'm Kate Johnson from Medscape. Dr. Kobinger, I just wanted to ask you a quick question about, of the 2 vaccines that you mentioned, which one of them is the one that you recently published on? And secondly, this morning you talked about convalescent blood and the fact that it was not very effective in the past, and yet you said out of the WHO meeting there's a lot of hope for it now. Why is that, and should there be hope?
Yeah, 2 very good questions. So to clarify, there was 2, there was a lot of different studies that were published recently, but so one was about the treatment ZMapp, and one was on the chimpanzee-derived adenovirus. This was published by a group at NIID with Nancy Sullivan's group was the lead. There's a lot of publication on VSV as well. So I'm sorry, what was the question related to this? Because what I'm saying is, if you want to hear about the chimp adenovirus vaccine.
I just wanted to know about the 2 viruses, the 2 vaccines that you mentioned, but there was one that you recently published on in rodents, right?
Yeah, so what we published on very recently is the treatment. It's not a vaccine. It's a treatment based on 3 monoclonal antibodies. The vaccine was also published, but not by us. It was published by Nancy Sullivan's group. So the other part is, what was done in the past in Kikwit, for example, 95, which is what I mentioned, that had not conclusively shown that transfer of plasma was beneficial. Again, it was a bit curious because 6 out of the 7 that had received the plasma survived, and there was a lot of question about whether or not it had worked because of fact that some of them were recovering. It was not a controlled study, so it leaves everything a little bit with a big question mark. As for what we're going through right now with ZMapp that has been administered to 7 patients, I totally agree. It's impossible to really learn a lot because they are basically anecdotal. So this is why it's so important to have those studies, phase 1 clinical trials, and so on, so that we can understand better the benefit associate, and then we can associate them with the risk.
So another question from the chat room. Rob Nickel of Reuters asks for Dr. Kobinger, is the National Microbiology Lab in Winnipeg working on Ebola projects beyond the Canadian vaccine that was licensed to Newlink in the treatment ZMapp?
Yes, the answer is yes. We're trying to understand also the pathology associated with this virus that is circulating right now. We're doing a lot of other, we're developing, trying to always improve our diagnostic tests for detection. So yes, there's more than the vaccine and the ZMapp. Although the vaccine and the ZMapp were priorities and still are.
Michael Smith, MedPage. Actually, Dr. Mehta, people have tried to pin you down a couple of times, and you've skittered away. I'm just trying. What did you guys do that you can now share with your African colleagues that they perhaps were not able to do or had not thought of doing in the care of these 2 patients?
Sure. I did not mean to skitter around any questions. And we'll talk about this later this afternoon as well. So there was ability to correct specific electrolytes, and we think that might have had an impact. It's hard to say for sure because, again, we're only talking about 2 patients. the ability to switch between different types of IV fluids to meet the patient's specific needs at the time. We also were able to give high-quality nutrition, liquid nutrition to our patients to boost their protein levels, their minerals, vitamins, and other nutrients to help build back that immune system that was under attack. And also, one of the things that we learned was the power of close monitoring and in high-level nursing care to these patients. And that's something both the patients who were over there taking care of patients with Ebola commented back to us as being part of the impact of the care that we delivered. I hope that answered your question. Okay.
Hi, Simeon Bennett from Bloomberg again. For Dr. Kobinger, how is this current outbreak changing the dynamics of Ebola generally? And what I mean is, once this, we're used to seeing Ebola outbreaks, once every year or two in rural areas, relatively small until now, containable. Obviously, we're seeing something on a completely different scale now. Are we going to go? Is this just a once-off freak event, and we're going to go back to seeing these kind of much smaller, more sporadic outbreaks, or has this changed the landscape for Ebola completely? And is there a risk now that Ebola becomes endemic in West Africa or in other parts of Africa? Are we going to see more of these larger outbreaks?
Again, I don't know the future, of course, but I think one thing to reflect on is in the past, Ebola was not a public health problem. Put it in relation to other infectious diseases like HIV, like malaria, like dengue. It was not considered a public health problem. Maybe now this can be discussed more in more depth, but definitely this has changed. I think the perception that the virus can replicate and spread to wide areas and different countries. So in that respect, but I think, with the very important steps that are being made forward from the clinical perspective, from the response perspective, from experimental vaccine and drugs, I'm myself certainly hoping that this is the last large outbreak, because in the future, in terms of Ebola, Zaire at least, we will have options to add to all the tools that we already have, and I think it can only help bring the next one under control even more rapidly. So that's really the hope right now.
Okay, we have one last question.
Yeah, Nathan Seppa, Science News. Well, about the public health aspect of this, do you have any updated information on the Port Harcourt outbreak, just because it is a port town with 1 million people?
So the information that we have from the teams that are responding to the outbreak in Nigeria is that indeed there is a lot of activity to identify the people who had contact with the person who traveled to Port Harcourt and became infected there, and then the doctor who became infected from that patient. And there's a lot of activity underway to identify those persons and follow them every day. And from what we have gathered, there's been a number of people that have been identified, and the tracing thus far is a success, but every day is very important in terms of making sure that those people continue to be under that surveillance.
Okay, I'd like to thank my guests, Lieutenant Commander Barbara Knust of the Centers for Disease Control and Prevention. You can catch her talk today at 4:15. Dr. Aneesh Mehta, you can also catch his talk later today, right after Dr. Knust, from the Emory School of Medicine, and Dr. Gary Kobinger of the National Laboratories of Canada from Winnipeg, Canada, for their expert commentary on this emerging crisis with Ebola. You've been watching ASM Live here at the 54th Annual Interscience Conference on Antimicrobial Agents and Chemotherapy. I'm Michael Schmidt from This Week in Microbiology, and listen for us again as we discuss the unseen life of our planet on TWIM. Thank you, everybody.
Once you're in the BSL-4 space, the only way you can get out is to go through a chemical shock.
It's an unusual room, never seen anything like this. Anybody who has access to this facility first has to go through an R scan. So the HEPA filters filter the air coming out of the facility, and that will remove bacteria, viruses, anything that might constitute any kind of risk, right? Remember, this building is basically a second building inside the main building.